Good evening, everyone, and welcome to the Health and Social Care Scrutiny Commission. My name is Councillor Susanna Bacho, and I'm the chair of the commission. Before we start the meeting, I have a few housekeeping announcements to make. There are no planned fire alarms this evening. If you hear the fire alarm, please leave by the nearest fire exit and make your way to the agreed assembly point, which is St. John's Courtyard off Duro Street. Council security staffs will be available to direct you. The public toilets are located off the main reception area. Please switch your mobile phone to silent while in the meeting room. The meeting is being live streamed by Southwark Council YouTube channel. A recording of the meeting will also be available on YouTube after the meeting has ended. May I remind members to raise their hands if they wish to speak, and please wait until I give them permission to speak before contributing. Members of the public are welcome to record, screenshot, or post the public proceeding of the meeting. A copy of the council protocol for recording and filming is available on Southwark web. Apologies. Julie?
Apologies, Councillor, from the Vice Chair, Councillor Maria Linford Hall. We also have apologies from Susan Rule, and we have apologies from Councillor Charlie Smith as well, I believe.
Yes. And Naima and Sandra?
Oh, yes.
Okay.
Yes. And Councillor Naima Ali.
Yeah, okay. Thank you. Notification of any items of business which the chair seems urgent. There are no late urgent notifications. Disclose of interest and dispenses. Does any member wish to declare any dispenses? No, thank you. Can we then go through the minutes of the last meeting, which I would take you page by page, page 1, page 2, page 3, page 4, page 5, page 6, page 7, page 8, page 9, and page 10. Do I take that as an agreement, Councillor Esme? Thank you. We're now going to move on to our next agenda on the list, which is a presentation to be given by Mr. Hatta Hamad on menopause. Could you please come forward and take a seat? Okay. And can I also invite Beth to also take a seat? Yep. Okay. If you would please like to introduce yourself one after the other, and then we'll start from there. Thank you.
Good evening, everyone. I'm Haytham Hammoud. I'm a consultant gynecologist at King's College Hospital. I lead the menopause service at King's, and I'm past chair of the British Menopause Society and trustee of the British Menopause Society. Nice to meet you all.
Thank you.
Hi, I'm Dr. Beth Jones. I'm a GP in Southwark. I'm the clinical lead for long-acting reversible contraception with Southwark Council, and I'm the clinical and care professional lead for women and girls' health in South East London.
Thank you. We'll start with you first, and we'll give you 15 minutes to present your slide. Thank you.
Okay, so thank you for asking me to do this presentation. So I'll try and cover a little bit of clinical background, but also try and conclude and concentrate more about what's going on in relation to training and education. So next slide, please. So if we start with the basics of what the menopause is, menopause marks the end of the reproductive life cycle and can really have many consequences, short-term and long-term. Next slide, please. So if we look at the age of distribution of the menopause, the average age is 45 to 55, but it's important to keep in mind that about 7 out of 100 women can go into menopause beyond the age of 55. And if you look at the earlier group, so you've got about 10 out of 100 women may go into menopause between 40 and 45, and about 4% can go into the menopause before the age of 40. So higher than figures that we had previously quoted. So, and of course, this could have a significant impact on bone, cardiovascular, cognitive health when you go into an early menopause, as well as the potential impact on quality of life with the symptoms. Next slide, please. So again, I'll try and skip some of these just for the sake of time. So menopause symptoms are common, but it's also relevant to keep in mind not every woman will have symptoms. So you could say three out of 4 women have symptoms, 1 out of 4 don't. Of women who have symptoms, 25% will have severe symptoms, and 50% of women have symptoms in between. So that can vary. Also, the long forward projection of symptoms, if you look at them, average duration is over 7 years, but 1 in 3 women can have symptoms beyond that and into their 60s and beyond. So individualization is really key in the management. Next slide, please. Again, this is really kind of probably small writing, so apologies about that. If you just click on next, it'll just go until it shows the boxes. Next slide, and next. Thank you. So, I mean, again, if you look at symptoms, if you ask someone, what do you think menopause symptoms are, most people will quote flushes and sweats. And yes, they are the commonest symptoms. So the majority of women going through the menopause have flushes and night sweats. But if you look at the prevalence of symptoms in this review, it's really surprising how high up the list anxiety, mood changes, brain fog is. And so if you just keep clicking on next for a couple more times, next again, next one. So you could see the bottom one is brain fog and forgetfulness, and you could see how high that is in this literature review. So not everyone will have flushes and sweats, so it's important that when you're counseling people that these symptoms are all considered in this discussion, because all of these can have varied effects. So there could be physical, there could be psychological symptoms, and flushes and sweats are one aspect of this. Next slide, please. So in a menopause clinic, what is our role? What do we look at the lines of management? Lines of management, really, to me, the most important one is not a question of saying what HRT preparation should you take. It's more a question of understanding where you are, what's going on, what your choices are. That is key. Not everyone needs to take HRT. Not everyone wants to take HRT. Many do, and many will benefit from it, and to many it'll be life-changing, but it's important to understand that wider aspect. So access to information is relevant, and in this day and age of social media and the mad crazy information that's been thrown out there, lots of misinformation, lots of probably well-intended misinformation, it's important to guide women to accurate information, to know where to look, what to look for, and what to expect, because setting a high bar of unrealistic expectations can also be counterproductive. So guiding women to where to go to get information, helping them understand where they are is key. And of course, understanding options, HRT and alternatives, and lifestyle changes for general health, but also for symptom management is very relevant. Next slide, please. So what are the indications that we give HRT for? The commonest one, because in the context of general population, is menopause symptom management. But I touched on, and I'll leave it just for the sake of time, but happy to take questions later on. Premature ovarian insufficiency and early menopause, a very important aspect of general health. Bone, cardiovascular, and cognitive comes into this discussion as well. And of course, osteoporosis management. Next slide, please. And next slide, please. Thank you. So this is just putting different preparations. So you've got the estrogen patches at the top, estrogen gel preparations, and the marginalized progesterone. You've got the testosterone preparations that we're using out of license, and also Androfem, which is the Australian product that is likely to hopefully appear in the UK later on this year. Next slide, please. So when we talk about indications, we talked about symptom management. HRT remains the most effective intervention for managing symptoms, but also it's important to look at it and say that we should not set arbitrary limits. Individualization is key in relation to age, duration, dose. It's really important to look what does the individual need, where are they, and how can you optimize their management. Next slide, please. And of course, when we talk about HRT for symptom management, the parallel question is what are the benefits and what are the risks? And of course, there are plenty of benefits. So there's bone and cardiovascular benefits, a significant reduction in osteoporosis and osteoporosis-related fractures. Next slide, please. Significant protection against coronary heart disease when HRT started under the age of 60. So there has been good evidence to show that there is a reduction in coronary heart disease, cardiovascular mortality from the Cochrane database information, as well as all-cause mortality. So these are the benefits in parallel. So we don't advocate HRT beyond the age of 50 for prevention, because the balance of net balance of benefits and risks doesn't quite quantify to support that, but certainly there are benefits and they're relevant. Next slide, please. But of course, the point that often people worry about is the risk of breast cancer with HRT. And whilst there is a small increase in risk of breast cancer, it's important to put it in context. The risk itself is low. So if you look at these figures from the NICE database, and they base their information heavily on the observational data, which are slightly higher than what the randomized data show. So you can see that most women who take HRT most women who get breast cancer are not on HRT, and most women who take HRT don't get breast cancer. And I think it's important to put this in context. Even if you take HRT for a 20-year period, you could see an increase in risk of breast cancer over time, but small increase, and the majority of women in that group don't get breast cancer. And I think it's important to put it in context. Also to say, when you put all the benefits and risks together, bone, cardiovascular, and breast, there's a reduction in all-cause mortality. So the benefits outweigh the risks. Next slide, please. And also, if you look at this figure, many of you may have seen it, where you look at the risk of breast cancer in relation to other lifestyle risk factors, such as, like I say, daily drinking of alcohol or obesity. There is a higher increase, more of an association of breast cancer with alcohol intake and with obesity than there is with HRT. So just to put it in that context. Next slide, please. So to sum up in this section is to say that HRT shouldn't be seen as one intervention. The risk overall, any risks associated with HRT are low, should be taken in the overall context of benefits and risks. And for most people, the benefits outweigh the risks. Next slide, please. And again, this key point of saying that it's about individualization, it's about access to accurate information, looking at the patient overall in a wider context, and coming up with kind of a plan to help them, support them where they are. Next slide, please. So the next section, I'm just going to talk a little bit about what resources the British Menopause Society has done over the years to try and support really healthcare professionals as well as the public. We're all aware that there's so much information, there's a flood of information, and people are busy. So no one has got the time. If you go into any website, if you go into the BMS website, you'll find all sorts of information. Most people wouldn't go from one box to the other. So it's almost saying, like, if you're going to go in, what's going to grab you? What's going to get this information right straight in front of you when you go in? So the BMS Resources Toolkit, this is really goes from the basics and way beyond that. It's good for patients, it's good for doctors, it's good for specialists. You could get a really good update with that. Lots of videos, short videos, a series of 20 videos. And what is the menopause? What are the benefits? What are the risks? So if you get next slide. So if you click on, so you'll get pages like this. So for example, if you click on what is the menopause and you click on next, it takes you to this one, for example, Menopause Wellness Hub. And within this, you've got, like, for example, this video on menopause weight gain, 5 minutes, and so on. So there is sleep, 5 minutes, early menopause, they're short videos, and they're really suited for all. And we very much would hope that this would be utilized as a tool. If you're trying to promote, awareness, giving links to this we would recommend that. Next slide, please. So in addition to that, and sorry, the screen, this is all coming very small. These are the various other educational material that we have done. So the Principles of Practice of Menopause Care, the PPMC program that was launched in 2020. This really kind of became the standalone British Menopause Society training program to train healthcare professionals, and that's been running. So far we've got over 500 BMS recognised specialists who have completed the advanced certificate within the last 5 years. But also we've also been aware of the bottleneck. So you've got lots of people who would say, "I'm really keen to do it. I can't find a trainer." So really the answer to that was to say that we need to try and move away from having a trainer to have an online educational tool that is very heavy on clinical theory but also practical, but doesn't need a trainer. And that's where the bottom left, the menopause management of menopause certificate online program came in. I would say that's probably one of the most important milestones in British Menopause Society history, because that's really opened up a door to lots of people. And so far this was launched just over a year ago. We've had over 2,000 people, GPs, healthcare professionals, doctors, and nurses, etc., who have enrolled to it. And this has got a huge potential for most menopause care. This should provide enough information to do that. The BMS handbook also is now in the process of being updated. And we've got also with the BMS menopause trainers register, so whoever's a specialist, we advise them to and encourage them to kind of become menopause trainers, and we've got a register for that. And also the BMS master classes, so these are evening classes that the BMS runs about 3-4 times a year, where they're open to GPs, and we have about 300-400 people attending these on each occasion, and it's really popular and very practical as well. Next slide, please. So, and again, this is the British Menopause Society consensus statement. This is now we're in the process of updating it as well again, but this really provides a detailed summary. It's in the public domain, and again, we encourage healthcare professionals to use it, but we also give this information to patients. I mean, patients, when you give them, they look at the executive summary, there's lots of information, up-to-date evidence, and really most of the messages in it still stand because it captures the most recent studies that current guidelines are based on. Next slide, please. And this, again, this national guideline on management of unscheduled bleeding, this has really kind of been done by multiple organizations, British Menopause Society, Royal College of Obstetricians and Gynecologists, GERFT, and others. So it's a really national guideline that's been adapted locally in many different places to provide kind of advice in this area. Next slide, please. So in the coming few slides, to conclude, I'm just going to talk about what we have done in South East London. So in South East London, we've got our South East London Menopause Network, and really, so one of the good things about it is things have moved very quickly within it. Most of you would be aware, with committees and organisations, things just take a while to move. And really, with this video, I say, in a very short period of time, a lot has been achieved in relation to guidelines, in relation to pushing things through formularies. And I think it's a really good example of how things can be done. So on the left, and so excuse the small writing, but this is the guideline itself about menopause, a very practical flow chart to GPs of what to do, what supports the evidence, where it comes from. We've managed to push lots of areas that have medications that have been available that haven't been there through the formulary to make it easier for GPs to prescribe. Again, we've also had a patient group and public support group, lots of evenings for supporting GPs, lots of evenings for giving talks to support the public. And I think this is all really kind of, welcome work and good. Really what I would like to see moving forward is how could we further things locally. I would like to see from different GP surgeries is to have at least one GP in each surgery with a special interest in menopause. So it's almost saying that the criteria for surgeries is to say they would have at least one person. There is a postcode lottery. I would always say most GPs out there are very, very good, but not all are up to date, all are interested in this area. And if you're in a surgery where no one is interested, that's a hard stop for you as an individual. And I don't think that postcode lottery should be the case. And of course, what I would suggest with that as well is when I'm talking about the online certificate, is to say if the councils collectively or the network looks at funding, it's nothing ridiculous, but funding one GP in each practice to do the BMS management of the menopause certificate, then you're going to have one person at least in each surgery who is very much up to date with training. And I think that'll take out that postcode lottery. You could say one individual has got a special interest in that. So that's kind of from each primary, from each surgery point of view or practice. The other thing really is primary care hubs. And again, we've had discussions with these. I think at some stage of the discussion there might be money, and then it came to a stop because the money wasn't available. And I think in this day and age, one thing the pandemic taught us is you can do a lot virtually. I mean, our service didn't stop for a single clinic during the pandemic because we moved from a really busy service that was done face-to-face to the same service running exactly the same way virtually. And we didn't cancel clinics even at the height of the pandemic. And of course, what you could take from that now, there's a lot of potential for virtual appointments. So again, one thing I would encourage to look at and try and create some funding for is to have primary care hubs. Even if these are started on a really, really small scale, you could have 2 sessions a week, 3 sessions a week. You could expand them as much as you would want. You could have a BMS menopause specialist GP who runs them, and they could then there'll be support for a wider group in primary care, and they could have support from us through advice and guidance or through whatever sessions we do, MDTs, to support that. And I think that'll create some middle ground between primary care, which can carry on doing exactly what they're doing, and what we're doing. We're just inundated with the waiting times, but that will be a good middle ground. It'll be less inconvenience for women because it'll be local, but also they could link directly with support for surgery. So I would say, of course, I'd be happy to be involved in discussions around that in the future, and now if that'll be of help. Thank you. Next slide, please. And that's the end of my presentation, but happy to take any questions.
Thank you very much. We would first have Dr. Beth to give her own presentation, then we'll ask questions. I'm afraid you have only 10 minutes.
No, that's absolutely fine. And have you got the slides? Great. So I will talk a little bit about the sort of hyper-local picture here in Southwark, and add a bit more kind of national context as well, things that are going on more generally and things that are a bit more primary care focused. So if you could put the first slide up. While you do that, I'll just give a bit of background. So we both work across South East London. South East London is made up of 6 boroughs, so Southwark, Lambeth, Lewisham, Bromley, Bexley and Greenwich. So we've got sort of South East London wide initiatives, and we've got sort of local Southwark initiatives. There are 2 primary care networks in Southwark. So primary care network is a sort of a group of GP practices which work together and co-commission services and things like that meet the needs of their specific local population. So some of the boroughs in South East London have sort of, more than 10 primary care networks. Here in Southwark, we only have 2. So we have North Southwark and South Southwark. So I'll give a bit of context as to what the situation is in both of those PCNs, and what the opportunities are. Perfect, thank you. So if you could go on to the first slide. So I'm just going to talk a bit about the national picture in relation to menopause, sort of general NHS updates. So here are some sort of screen grabs of press releases. So top left, you can see that this is a report about the increase in HRT prescriptions from 2022 to 23 to 2023 to 24. So there was a 22% increase in HRT prescriptions between those 2 financial years. We haven't got the data for 24 to 25, but it gives an impression of kind of how much demand is increasing. And I think most importantly, underneath it says the least deprived areas in England had more than twice as many eligible patients receiving HRT compared to the most deprived areas. So there's an inequality in terms of HRT prescribing. Bottom left, again, this is a current initiative, so I think this was from 2021 it was introduced, HRT prepayment certificate, so you pay just under £20 and it covers all of your HRT prescriptions for a year. So again, that's trying to sort of reduce health inequalities in terms of access to menopause and menopause care. And then on the right, these are sort of future prospects. So bringing menopause questions into routine health checks. So everyone over the age of 40 is offered a routine NHS health check. It involves things like weight, blood pressure, tests for sugar levels and cholesterol. And the plan is to introduce a question on menopause symptoms into that health check, so people have a sort of forum to talk about it. And we're still unsure what that's actually going to look like. And then bottom right, this is a more recent development that a new NHS online hospital is due to be launched in 2027. And this means that patients referred by their GP will be able to opt for an online appointment with a specialist rather than going to, a local service. We were talking before about how not all localities have a specialist menopause service. So you can choose an online appointment via your NHS app and you can access the service from home. So menopause is one of 9 key conditions that's going to be incorporated into that online hospital. And that kind of dovetails with what Haytham was saying about how the potentials associated with online appointments, people who are less mobile, etc. Next slide, please. So the local picture, so I was just talking about the 2 primary care networks in Southwark, North Southwark and South Southwark. There are about 20,000 women of menopausal age in each of them. So we've got a huge population of potential need. The graphs below, the data that it shows, so the one on the left shows H-scribing within Southwark, and it compares the PCNs according to deprivation decile. So the 2 orange arrows point to, the one sort of further left points to South Southwark and the one further right points to North Southwark. Those are those 2 PCNs, and the sort of height of the dot shows how much HRT is being prescribed compared to other PCNs with a similar structure in terms of deprivation. So we're prescribing a lot of HRT in Southwark compared to other PCNs in South East London with a similar kind of population structure. So, I think we're doing pretty well here. If you looked at the 2 outliers, you would pick those 2 out, especially so the lower the number, the higher the level of deprivation. So we're doing pretty well compared to our peers across South East London. So that's on the left. On the right, same again. The 2 orange arrows indicate South Southwark and North Southwark, and this is where you compare our PCN to other PCNs with a similar ethnic makeup across South East London. So again, we have a high level of need, but also a high level of HRT prescribing. Why is there a difference between North and South Southwark? I suppose it's worth mentioning that South Southwark does have one of these primary care women's health clinics, so that might be a contributing factor. And it's also kind of to go back to what I was saying in the first slide, worth noting that in general, in areas of higher deprivation, HRT prescribing is lower. So I think we are doing pretty well. Another thing to say, again, as Haytham said, not everybody wants HRT. So I suppose we can't directly say that this is a sign of success. Not everyone wants it, not everyone needs it. The aim is not to get everyone on it, but to reduce inequalities in prescribing and in access. So I think that that's something that we're achieving. Can we have the next slide? This is another graph which compares us to similar PCNs across the country. So we're not just being compared to South East London, we're being compared to a sort of random selection of PCNs with a similar ethnic makeup or similar deprivation across the country. And the dotted line that goes horizontally is the average. So we are below average in terms of HRT prescribing compared to other similar PCNs across the country. And that's perhaps something that we can work on. So there is room for, more work to be done. In terms of what the barriers are, so we've already heard about a couple of them. One of them is obviously funding. So the central government gave every ICB a certain amount, so almost £600,000 of non-recurrent funding to set up women's health hubs in that ICB. In South East London, the pilot sites were set up in Lambeth and Greenwich and Bexley, so Southwark didn't get a chunk of that money. So we're kind of responsible for figuring out how we can put together the services that already exist and the budgets that already exist to try and develop something similar. That funding was non-recurrent anyway, so whatever services were established, they have to find sustainability funding to keep them going. There are also things that are slightly disjointed in terms of budgets, as you may know. So, for example, the Marina coil can be used as part of HRT, but it's also used for contraception. When GPs insert these coils, they are repaid by the local authority from the public health budget if it's inserted for a contraceptive reason, so because it's considered a public health issue, but they're not reimbursed if it's inserted just for HRT. So this is something that we've looked at trying to address, but it is quite tricky, trying to take from certain budgets to do something different. And then I think in terms of facilitators, so there's a high demand, as we know, there's a sort of high level of need in the population, and there is a lot of motivation amongst clinicians. There's a lot of interest in all the training that Haytham was talking about, and hopefully it is something that, where we can match those two together. Can we have the next slide? So this is a bit clunky. It's quite difficult to interpret, but this is basically, I just wanted to show that we are making progress in terms of actually gathering data, because as you can probably tell, a lot of the data we have relies on HRT prescriptions, because GPs, we're not very good at coding just an attendance about menopause. So in order to capture that information, the GP would have had to, enter a specific code. So we don't really know how many consultations there are where the patient hasn't had HRT, but they've just wanted to talk about their menopause symptoms. So we're trying to get that data together, and this is a dashboard that's being developed by the business intelligence team from South East London, and it shows us menopause consultations in primary care compared to other boroughs in South East London. And so I've highlighted Southwark there. And again, maybe you want to look at this in your own time, but we're doing relatively well compared to the other boroughs in terms of, how many of these consultations we're conducting. So this is hopefully going to be launched and be publicly available to commissioners, public health teams, etc. So it can be used for planning and evaluating services and so on. So this might also help us to sort of build a business case for more menopause services in primary care. Can we have the next slide? So how are we kind of getting around some of these barriers locally? So we were hearing about how there's a bottleneck, there's a shortage of trainers. Lots of people want to do the BMS training, but there is a cost associated with it. So we've developed a local South East London primary care menopause course, which will be running next month. And the idea of that is to again address inequalities in terms of who can access specialist menopause training. So the faculty are specialists from Guy's and St Thomas's and other local services, all local experts, and we want to disseminate the knowledge and skills as far as we can across our clinicians in South East London without having to sort of pick and choose who we can afford to send on these other specialist courses. So we've got accommodating about 100 people in the first run, and we're hoping to run it again more broadly online next time probably. We've got courses in pessary fitting, so sort of urogynecological problems often come alongside menopause. People often can find it difficult to get treatment in primary care and are sitting on long waiting lists to see secondary care. So again, we're hoping to bring that into primary care. And we've had webinars on lifestyle medicine in menopause and just how to have conversations around women's health, the appropriate language to use, how to overcome what clinicians might think is going to be an awkward conversation, and they're available to all clinicians across South East London on demand. And we've got these we've got resources available to all the clinicians as well. So we have a 2-monthly network meeting where anyone can join. It's an open invitation. Anyone here would be very welcome to join. We actually had Naima speak for us at one of our meetings, and we put all of our resources together on a Padlet where we have things like easy read resources on menopause for patients with learning disabilities, for example, local guidelines on prescribing. You were talking about the national guidelines on unscheduled bleeding and how there's a kind of more concise South East London version of that. So that's available on there as well. And that's, one handy place for clinicians to access all of these resources. And I think that's my last slide. Yeah, so I'm happy to take any questions.
Thank you very much for presenting the 2 slides. I'm just going to ask one question before I go to Esme. You said there are signs for this menopause, and either through people having cold and hot, but the one that I'm really interested in is the one you say where the brain freezes or something. How do you really know what the actual person, what kind of sign that person has?
Yeah. It's a good question. I mean, of course, the relevant point to say with this is lots of the symptoms, this included, can overlap and be caused by many different things. So if you look at the long list of menopause symptoms, most of the symptoms can be caused by other aspects. So you always have to look at the wider picture. And you could say if you're first of all, brain fog itself, even though we use that term, it's not really a scientific term, but it's been used and now very much accepted, but refers to changes in memory, recall, concentration. So that can be caused. What causes it with the menopause? It could be a direct or an indirect effect. Let's say if you have hot flushes and night sweats, you wake up at night, you don't sleep well, the next day you're going to be tired, that can give you that brain fog sensation and can make you anxious and make you feel low. Or it could be the other way around. It could be you're not sleeping well just directly as an effect of estrogen deficiency, and that starts the domino effect. Or it could be that your mood is low and you're anxious, and that could give you that sensation of brain fog. Or maybe there is a direct effect, we don't know. It's because of this overlap, it's very difficult to pinpoint and very difficult to look at in studies. So generally, it's a subjective sensation, going back to a more practical answer to your question. It's a subjective sensation. If you say, I have noted over the last few months that I'm noticing this. Nothing has changed in my life. My work is as stressful as it is. Everything is in my life is the same. I'm not sleeping well. My memory and concentration is not great. I'm waking up at night. I'm feeling low, feeling anxious. So it's the timing often that is relevant. And the next bit would be, if you're starting treatment, is the response to the treatment. So if you take HRT and you say, I've noted an improvement, but I've still got symptoms, we up the dose slightly, you notice more improvement, that'll tell you it's more likely to be hormone related. And equally, when you probably see the Panorama program 2 years ago, where people on ridiculous doses, and basically what happens, you say, I'm not feeling good, and I give you this, and you say, I'm still not feeling good, I'll say to you, double it up. And you say, I'm still not feeling good, I'll say to you, double it up. And if it's not the cause of your problem in the first place, you could go up to these crazy doses that you saw on the program because it's the wrong panel, it's the wrong path to take. So it's really kind of, that's what I was about individualization, to say the timing and the response to the treatment is really kind of an important part in answering that, keeping in mind it's often multifactorial. I mean, often nowadays we want to put everything in a box. It's either menopause or it's not menopause. And in reality, it's often an overlap. It's probably partly menopause and partly stress and partly not getting enough sleep and so on, all together.
Councillor Esme?
Hello, thank you both very much for your presentations. I suppose it's a question for Dr. Beth, really. It sounds like there's still more to be done, but would you say that things are better now than they were, so for example, 13 years ago? Do you think they are better now?
I think they definitely are. I think there's much more awareness amongst clinicians and amongst patients of menopause symptoms. I think there's, as I was saying, there's motivation amongst clinicians, especially amongst GPs, to learn more about menopause. It's seen as a very specialist area, and it appeals to GPs, even though we're generalists, to have a special interest. And so I think there's certainly potential for a menopause specialist to exist in every practice. In terms of sort of patient awareness and things, I think it's always good to be aware of one's own symptoms and what might be happening. I would just kind of advise caution about where patients access their information. I think that's the only thing that we have to be careful about. There was a study in the BMJ last year which showed that they took a sample of menopause kind of in the media, facts about menopause in the media, and about 70% of them weren't aligned with national guidelines, and about 70% of them were associated with some kind of commercial gain. So someone is trying to sell a product or is offering private practice or something like that. And so we often have to contend with a lot of preconceptions which might come from those kinds of sources. So it's an opportunity for kind of building a shared understanding between the patient and the doctor, and trying to come up with a personalised plan.
I say 13 years ago because that's when I had mine. So my husband had a young onset Alzheimer's, and the stress of me looking after him brought about a sort of early onset menopause in me. And the colleague said that hot flushes are not necessarily a symptom. I basically started experiencing them, and when you experience it for the first time, it's like, what's this? Don't really know what this is. So I made an appointment with the GP to say, what is this? And she just categorically said to me, you're too young. So I'd like to hope things are a bit better.
Things have changed. I mean, if you kind of go to the background of all of this, is in 2002 and 2003, two studies, the Women Health Initiative and the Million Women Study, were published, and it wasn't just what they showed. I mean, you could take the numbers now and say, what I've just presented, this is where I presented the numbers from. It's a question of how do you make the conclusion. If I say to you, the risk is 1 extra case per 1,000, you might say, well, that's not too much. But if I say to you there was a significant increase in the risk of breast cancer, you'd be thinking, so you use the same wording. And so what these two created a really negative message. The MHRA took it. The MHRA recommendations of that sadly haven't changed since then. So you had a whole decade following on from that, actually longer than a decade, till 2015, where that negative message was out there. Of course, the turning point was the NICE guideline. So the NICE guideline of 2015 was where it really put the same information in a slightly different light to say, look at things in a balanced way. That was really the summary of that whole entire guideline. And I would say the last decade has become a follow-on from that, where people have taken that. And of course, some people have taken it to an extreme, where they're over-positive, thinking it's the answer to every problem out there, which it's not. But certainly that was kind of, I would say, the turning point in many ways.
Thank you very much for coming, and you're free. If you want to wait and listen to the rest of the conversation, you're okay too. And if you want to take your leave, you're okay too.
Thanks very much.
Thank you.
Thank you. I'd like to welcome Dr. Martins. He's online, and if you can introduce yourself and tell us about a little bit about yourself, and also give us the presentation. Thank you.
Okay, good evening. Can you hear me?
Yes, we can.
Good. Okay. Yeah. So, Dr. Martin Burke. I am an architect by background. I work at the University of Stirling, both in the Dementia Services Development Centre and as a lecturer in design for aging and dementia. So I've been at the university for about 10 years, and I had a PhD from the University of Newcastle in Australia, which focused on the sort of early design stages for care homes in particular, which I think is part of the reason why I've been invited along to speak this evening. I've got some slides that I will attempt to share. Start. Try this again. Okay. So again, thank you for the invitation to speak. I've been asked to talk about the main principles of good dimensional design for care homes, with particular interest in space standards.
Sorry, can you just bear with us one moment? We're just working out how to do the slides and show it.
He's sharing.
Oh, but we can't see them.
We can't see them.
No, we can't see your slides at the moment, so just trying to figure out how to do that.
Yeah, it came on when he started sharing, but it went off again.
I wonder if he needs to log on. Hi Martin, yeah, I think you need to share your screen again. It popped up and then it's gone. Yep, we can see them now, that's perfect. You just need to unmute.
You love the technology. Yeah, it's misbehaving at my end. Not able to control it. There we go. Right. Okay. So, yeah. So, thanks for the invitation. I've been asked to talk about the main principles of good dimension design as it comes to care homes, in particular, space standards was mentioned.
Sorry, Martin, to interrupt.
Yeah.
Sorry. There's a screen on your screen that is has popped up. Can you minimise that?
Oh.
It's the
Right.
Teams. Yeah. Can you minimise that?
Yeah.
Yes. Perfect. I think we're good to go.
I thought I'd shared through the app, but clearly not in the confusion of bringing it down and back up again. So in terms of planning policy, space standards usually mean minimum room sizes and minimum floor areas. So the example of historic minimum sizes for rooms in care homes, 12 square meters is often quoted, excluding the ensuite. Now, I'm not going to argue that these minimums are sufficient in practice, but many leading organizations tend to work kind of well beyond these numbers. So maybe it says something to do with the need for these to be updated. But I don't want to get hung up on the dimensions here, because the evidence from the research suggests that size by itself is a fairly blunt tool in terms of getting a sense of like how useful or supportive these environments are. So what matters more is how the space is planned, how rooms relate to each other, and then what can be seen from where, how the environment supports everyday life for the residents, rather than just the sort of the very practical care tasks side of things. So when dimension-friendly design is discussed publicly, it often ends up being reduced to visible features like signage, color contrast, murals, and some particular fixtures. So these things can help in the right context, but the strongest evidence actually suggests that the bigger design moves are elsewhere. So if we look back through the sort of the history of this research, work by folk like Mary Marshall in the UK and Richard Fleming and colleagues in Australia, and this is spanning several decades, it shows that the outcomes are much more strongly influenced by elements such as visual access between spaces, aspects such as noise and sounds, that sensory component, access to daylight and outdoor spaces, and whether the environment supports ordinary activity. So these are the things that are more likely to affect the overall well-being of the residents in the care home. I'm not going to talk through these 10 principles of dementia design that I've listed here. These are from Fleming and Bennett's work, which will become more relevant as I talk through here. The main point is that from this framework is that the spatial configuration matters a hell of a lot, and it means then that these early stages of the design process, so particularly that at that stage, say where the local authority is assessing a planning application, this is a really fundamental stage of the success or not of the design of a care home for its ability to support the well-being of the residents. So one of the central ideas behind my own PhD work and dementia design assessment tools like the Plan EAT, there's the Sterling tool, which is the Environments for Aging Dementia Design Audit tool that's used for the Sterling Gold Standard for dementia design. So these are fundamentally about relationships between spaces, especially the visual relationships. People living with dementia are generally far more likely to rely on what they can see around them rather than on memory or signage or kind of abstract understanding of that environment. So we test whether the design is likely to be successful then with questions such as, say, when someone steps out of a bedroom, can they see where to go next? When they're in a lounge, can they see the garden, or do you understand how to reach it? When they're in a dining area, can they see everyday activity taking place, such as the preparation of food? So that's a multi-sensory cue for them to engage in that dining experience or to partake in those ordinary activities that we often refer to, and certainly something that occupational therapists talk about, these activities of daily living as functional essential criteria for helping the person maintain as much independence as they can for as long as possible, and thereby reducing the dependence that they would have on the staff that are supporting them. But these questions, if the answer to these questions is no, then we are increasingly leading to a point where there is more reliance on the staff. So what we're essentially getting to is that design that helps the residents is in turn helping the staff. But there's also the element of what aspects of the design help the staff directly. These examples that I've just been talking about to do with visual access, they link to Fleming's principle on the sort of previous slide about allowing people to see and be seen. So there's an element here to do with wayfinding and orientation, but there's also an element to do with the social connections that are made in these environments. This is one of the examples from my work. So it's a famous one that you may have all seen in the media. It's called De Hodgeway in the Netherlands. It's a very well known, highly respected example internationally, and it was one of about 180 layouts that I assessed during the research. So when we analyze this on a dementia design principle basis, we see that it has strengths and weaknesses when we look at the spatial relationships. So the weaknesses here, which people might not realize that it has some, is that when people don't have en-suites in their bedrooms. This is a norm that we've come to accept here. When someone steps out of their bedroom, there's little visual information that helps guide them to the bathroom. So for residents in this unit, finding a toilet relies on signage or memory, or at least for some of the bedrooms anyway, relies on signage or memory rather than the environment doing the work. So this is not doesn't necessarily make this a bad example, because there are lots of really positive attributes to be learned from studying design like this. But it does tell us that even exemplary designs do have some degree of trade-off, and in this case, visual access is one of those. Another example from Japan, where the issues are slightly different. Here, the challenge is less about the internal navigation. It's a really simple layout. But what is missing or is not strong here is the connection to the outdoor space. So it's quite a limited amount of outdoor space, and it's not as easy to access as some of the other examples. And there's, I guess, more constraints here in terms of the social component, because all the social space is together, and you don't have options of being able to be separate from the main group. Say if someone has sensory issues with, when the space is loud, if there's a party or TV watching or something going on, they want to be able to have quieter, a solo or smaller group social interactions. So this isn't, again, about negative critique per se, but more about understanding how spatial decisions can shape daily life as far as the residents are concerned. Just get into a little bit more of the kind of brass tacks here. So in this slide, I've got two examples from following the same principles of visual access and spatial adjacency in action. On the right, when someone enters a building or moves between key spaces, can they see where the toilet is? That's always a question that we're asking in this process. If not, the environment is asking more of the person cognitively and of the staff operationally, to be able to do those normal kind of activities of daily life. The example on the left then looks at visual access with respect to the ensuite to a bedroom. So being able to see the toilet from the bed head, even partially, can make a difference between someone's independent use of the toilet, especially at night, and also the risk of them being diagnosed as incontinent, but it might not be anything biological, more just the problem solving of identifying the toilet and using it. In both cases, a small spatial decision may actually have disproportionate large consequences for both the dignity of the residents and the workload of the staff. Okay, so this slide shows a small sample of the care home layouts that I analysed, and you can maybe, I don't know if you can see it, but the smaller text underneath where there's a kind of percentage score. So what this starts to give us then, when we use using the Plan EAT tool. It's a plan specific assessment tool that I developed as part of my PhD. This gives us like an overall sense of the design quality of these environments. So each of them will have strengths and weaknesses, as I was talking about a couple of slides ago. But this kind of gives us a sense of the overall of the kinds of variations in layouts that may be possible, where one type of layout might be more suitable to a particular context, be that the number of residents or the site constraints or so on. So having these options, for architects to have these options up their sleeves, could be quite useful for them to just test ideas on a site where you're trying to develop a new facility. Once planning consent is granted, we have the issue where layouts are largely fixed. They're going to be, they rarely change after this in any meaningful way. So there's a powerful role that the local authority can have here in terms of, it's not about necessarily refining or defining minimum room sizes, but more about asking better questions early in the design process, as as a kind of gateway to the rest of the design process. And these, to me, would revolve around issues or questions about, are households spatially or operationally distinct? So what the evidence says is that we want to get to the point where we have more smaller households that are physically separated from each other. They have their own front door, for example, rather than kind of larger numbers of residents in a single unit. So the example might be to have 10 resident households rather than have 30 resident households. Even though that might be the same size building, the 6 by 10 is evidence to be really strongly to be much better for the outcomes, whatever way you measure it, for the residents. we'd ask, does each household feel like it's a recognisable home? Does it have its own front door without its own threshold? Do the layouts support everyday movement and choice without constant staff intervention? So if someone wants to go to the garden, are they able to do this? And do the staff feel that this is something that they can, that they feel comfortable doing in terms of that casual surveillance component? And is outdoor access part of daily life, not an exceptional event? There's a huge weight of evidence of this, the benefit of getting outside, especially in sunshine. This is in terms of vitamin D production, in terms of circadian rhythm, the sleep quality, and then in turn the moods and the energy and the even the behavioral symptoms that we often talk about. These can all be improved drastically by ensuring that the residents have good access to outdoor, good quality daylight on a daily basis. So these are scrutiny questions essentially about dignity, autonomy, staff workload, and long-term sustainability, not aesthetic preferences. And so I'll finish then by leaving with sort of 3 questions that should be useful when reviewing the proposals. So first, how does this layout support everyday life, not just care tasks? So what this maybe means then in the design process, we are trying to involve those delivering the care in the review of the designs, of developing the design briefs in the first place. So what risks are we assuming, or what assumptions are there about the risk aversion? So this idea of, can people go outside safely? The staffing ratios depending on the time of day and configuration and the number of residents that might be there, and how is autonomy kind of embedded within this? What can we do to maximize that? And a kind of interesting test with this is then, so what happens if a resident is left unprompted? What do they get up to, and where do they go? Are they supported in meaningful ways to find things to do, to be able to get outside, to be able to engage in activities that they find interesting and valuable? So if these kinds of questions don't go unanswered, or unanswered convincingly, then the environment is far more likely to go one way or the other in terms of those quality measures of supporting the residents' well-being, and then in turn, obviously the well-being of the staff too. Okay, so I'll finish there. Thank you for listening. I'm happy to take questions. I will make the slides available. I'll send them through to Julie, and then there's links in this sort of last page then to some of the documents that I've talked about.
Yeah, thank you, Dr. Martins. Even in the presentation, there is so much to thinking about and questions to ask. We will send the questions to the councillors in charge of the nursing home to see if they have really looked at it properly. Do you have any questions? No, I haven't got any questions now. Hold on, Councillor Esmin.
Hello, Dr. Quirk. It's Councillor Dobson here. Thank you so much for joining us this evening and for your presentation, which was very interesting. I guess a couple of things that came up from your presentation. One, which is I'm very keen on, given that we're embarking on a new project shortly, the Asylum Road project. The provider has been appointed. Apparently they have an architect, so I don't quite know where they're up to. But one thing I'm really keen on is the kind of basic layout of the building. So we had a nursing home built in 2022 by a provider, and we've had a recent story which you were involved in, the Love Walk one. And in both of those cases, the basic layout was kind of like a V shape, really, or sometimes they're like a star shape, but all of them result in this dead-end corridor sort of phenomenon, And so my husband has had young onset dementia, Alzheimer's, for 19 years, but he was what's called a walker, yeah? Even on anti-anxiety medication, he was walking 25 miles a day, yeah? And so when you have a basic layout where, so for example, Appleby Blue, which won the Sterling Prize, as far as I understand, that's got a kind of continuous kind of corridor layout. And I've visited other care homes as well that have thought about this and specifically designed it for walkers, because walking is quite common in dementia. So this is something I'm really keen that we get right. I don't know, like, I'm not involved in the process. I don't know where they're at and whether that's going to be taken into account. But would you say that that's kind of quite a common mistake, or a common kind of, like, how important do you think it is? And do you think it's quite common that we get that wrong as a basic kind of layout thing?
I think what you're talking about is that it's a fundamental component, considering the range of even different types of dementia that are accommodated. I suppose one thing that is maybe there's not so much awareness of is the shift over the last 20 years or so, that the proportion of people with dementia who are ending up in the residential care is much higher, and then the how advanced their dementia is increasing as well, and so it means that whilst this old, rather simplistic way of thinking about a layout may have worked up to a point, and I suppose the shift now to understand that a lot of the behavioural issues that that are associated with dementias are more and more. There's evidence to say that this is actually a stress response from the individual to the circumstance they found themselves in. So if the environment is not giving them a sense of where they are, of some meaningful things to do, to engage in, then you get some kind of behavioural responses to that. And then often it ends up becoming, a pharmacological kind of response by the staff to whether it's to ease someone who's agitated. But ultimately, as what you're getting at here is there's also the need to support those who do find basically a benign or a non-aggressive way of expressing that need to be doing something, to have that meaningful occupation, and so in the case of someone who wants to walk, or feels that need to walk kilometers per day, then that's not going to work very well in a really tight, restricted, central urban care situation, unless there's quite generous grounds, unless there's an assessment that says actually they're probably overall relatively safe, and maybe they could go to a park nearby, or maybe there's staffing provision that they take a go with. There's an example that comes to mind of just thinking about this connection back to the community that we've talked about before, Esme, where a facility in Yorkshire where there's a resident who had been a hill runner in their early days, and they kept essentially eloping from the care home, climbing over the fence and getting out. And their solution was, rather than lock the door and tie them to their bed, was the local running club started to come along, and they would take this gentleman out running in the hills a couple of times a week, and that was enough to help with the challenging behavior as some of the staff were seeing it. So I think there's this need for a holistic view of the person and their needs and their history. Let's get the design right, so we don't have any unnecessary problems arising. But this combination between the right kind of care and support as well as the design, I think that's where we need to be heading.
Thanks very much. Yeah, I mean that reminds me of kind of like So in my husband's case, it was young onset Alzheimer's. It was late 50s. It started. It took 5 years to get the diagnosis and stuff. And like the middle years were like he was very distressed, and I was consequently pretty distressed as well. And he did sort of move into a kind of assisted living place. But what we found, and I think is the problem throughout the country, that most of these places are designed for and cater for like 70, 80, 90-year-olds. And there's always like most homes just have like one young person. And there aren't like enough young people for a whole home. There was a place in Essex where they tried to do a home for young onset, and ultimately it didn't work apparently. So that's just a general challenge. Anyway, talking about hill running, etc., brings me on to my second question, which in your presentation you mentioned a sentence which I wrote down, and you said, is outdoor access a part of daily life or is it an exceptional event? So that was pretty key to me. Like, sadly, I think like a really standard care home design is having the kind of more able people and residents that don't necessarily have dementia on the ground floor, and then kind of dementia upstairs a bit more hidden away. And unless there's some kind of terrace, there's often no outside space at all. And therefore it becomes an exceptional event because it requires staff to bring somebody downstairs and to stay with them downstairs, and they generally don't have capacity to do that. So I just wondered whether you're aware of any research that's being done which sort of, like in terms of like evidence of like, to what extent, because for me, like, it's just like the average care home doesn't treat it as a part of daily life. They do treat it as an exceptional event, but maybe there are designs whereby, like, I remember you using the phrase something about passive surveillance or something. So like maybe if you had like an inner courtyard, again, like Appleby Blue, where staff can feel sufficiently, because a lot of it is down to staff anxiety around, we don't want to lose XYZ person, or if they fall over and we don't know, it's all of that kind of stuff. Do you know what I mean? So there must be design solutions almost that facilitate like the access to outside space. Could you say a bit more about that?
Yeah, I think you've hit the nail on the head with that particular issue. So there's at one level there's the kind of organizational attitude to risk. You never remove risk. You just shift it around. So they're saying, okay, we're not going to let someone outside because there's a risk of them falling. They're inevitably going to fall. It's just that if they haven't been outside for 6 months, then when they fall, they're far more likely to have a serious injury as a result of that fall. So there's something about shifting I guess that trigger, and the way I see it, and it certainly comes through in what the research evidence is saying, is that if, as you alluded to from the Appleby Blue examples, if the staff can see who's in the garden and what they're up to, then they're more likely to be comfortable, letting for those who are able to go by themselves, physically able to go by themselves, to let them doing it, so that they can still keep an eye on them. Whereas if you have a garden design where it's possible to go around the corner and be out of sight, then that does raise a degree of kind of stress and concern from the staff point of view. So it means then if you work all the way back, then they're less likely for that door to the garden to be unlocked first thing in the morning to begin with, because there's that worry there. So there's lots of examples of solutions that would work for that, and I think the courtyard example that you talked about could be a good way of doing that. And I think in terms of the operational side of things, there's a need to shift to the sort of risk assessment, if we're going to use this process, but make the assessment based on the individual rather than the sort of blanket thing that's applied to everyone. So we might have one person who is considered a risk, but then everyone who's staying there is subjected to the same restrictions because of that. And there's ethical things to consider, but there are technologies now that could allow this idea where only the person who's deemed to need that direct care or support to go outside, maybe there's something that prevents them from going out, but everyone else could. It's a tricky one to get right, but I think getting the spatial layout right to begin with is a damn good start on at least enabling the possibility that the resident would be able to get outside more often.
So just one final comment from me. I'm really passionate about people having access to fresh air and to sunshine. And I remember when we spoke once before, you said about it's almost illogical that the most able people are on the ground floor. Wouldn't it be more logical if the most able people were on the top floor because they can use stairs and lifts and stuff like that? Wouldn't it be nice if the bed-bound people were on the ground floor and you could literally wheel the hospital bed out into the courtyard? So for somebody even in the last couple of their weeks of their life could have fresh air and hear the birds and have the sunshine, because I don't think you need to... I think anyone, even somebody in the really late stages of dementia, could still appreciate those kinds of things. I think we have a really negative view of dementia in this country that, or maybe it's just general, that if somebody's cognitively very far advanced, they can't appreciate things, which I disagree with. So, and I think anyone can, even if they can't verbalise whether they appreciate it or not, I think anyone can appreciate, sunshine on your face. I think it was my husband's second care home, I think it was there was a lady who was complete, 99% of the time non-verbal, and she was in the sitting room one day, and she just suddenly one day she said, "Fresh air." That's the only thing I ever heard her say. And so then they did wheel her out. Fortunately she was on the ground floor, but I think we kind of underestimate the really basic pleasures in life that we kind of deny people. So I am very passionate about all of this. That my husband's incredibly late stage in terms of cognitively. Do you know what I mean? Mm-hmm. But we cuddle all the time, and that's another thing which I think is really sad about when you get to that stage, you have single beds in care homes or at homes and all the rest of it, and that kind of human touch thing, but that's still massively important for people, whatever stage they're at. Do you know what I mean? So that's why I'd like to. My husband's been lucky in a way because he had a great pension and all that kind of stuff, but I just think in terms of us aspiring to standards for people living in residential settings, we need to aim higher.
Yeah. Well, I suppose the angle that I tend to take on most of this is as much as there's some components of this which is about the person, enjoying their life, there's also, such a heavy weight of evidence about these kind of characteristics of the environment and daily life that helps to either improve or sustain the person's overall health and well-being. So I've probably several hours worth of lecture material on this thing about the exposure to daylight, about how it reduces the perception of pain, how it reduces your risk of cardiovascular disease, reduces your blood pressure. Never mind all, and then we get into all these things to do with vitamin D and circadian rhythm, and just the sheer opportunity then of more social interaction, of these other sensory stimuli that people can have, and they're usually positive stimuli when you're outdoors versus indoors when it's a care home, much more so. So it's those things that I would tend to latch on a bit more as a researcher, because I think unfortunately the sort of the very emotional sort of side of all of this doesn't tend to get much attention. Whereas if we can frame it genuinely around the person's well-being, we're happy to dish them out all sorts of kind of drugs and um, supplements to supposedly to maintain their health, but we don't do the simple and free action of letting them be outside for 10 minutes of a sunny day, or even a dull day for that matter. It just seems to be rather illogical. Again, there are practical reasons why it ends up being that way. We can hopefully do something about that. Even if it's the one instance of designing one care home right, and then let the world see that how well it could be done. And I think that's the Appleby Blue have done that for the housing industry now by showing how good housing can be. Yeah, I think you and I could talk for days about this topic. So
Thank you so much for joining us this evening.
No problem. Thank you.
Thank you very much. Yeah. We now move to the next agenda, which is access to toilets updates. Can I invite the two ladies, and sorry for keeping you waiting so long. Thank you for your patience. If you'd like to introduce yourself and start with your presentation, thank you.
Hi, I'm Tony Ainge and I'm Director of Leisure.
Hello everyone, my name's Tara Quinn. I'm the Head of Parks and Natural Environment. So basically I'm coming here today to update you on the Council's Toilet Action Plan, Public Toilet Action Plan. The reason I'm here is that I chair the working group that we formed since the Cabinet paper was submitted. So back in October 2024, this committee sort of publicised a paper on recommendations around the provision of public toilets. A subsequent report was then presented at Cabinet in response to those recommendations. And off the back of that, I've been working with various teams across the council on those recommendations. So that's what I wanted to update you today. So basically, what we've done since that point is we've formed a working group. That's involving approximately 10 teams from across the council of people who are involved in the provision of public toilets, the maintenance of public toilets, the cleaning of public toilets, the improvement and development of public toilets, the communications around our provision, and things like planning as well. What we've tended to focus on is taking the recommendations and it's working together to develop the Toilet Action Plan, which is in the paperwork in Appendix 1. And that's basically centred around the improvements of the standards of provision around the Council's existing public toilets, of which there are 37, and then working with businesses in the wider community to improve the number of public toilets available in town centres. And that's basically building on the previous work that's been done by town centre managers. It's also to improve the communications to inform residents and visitors to the borough on where the public toilets are, so they can actually find them, and there's resource available in terms of things like the toilet map, which is a national map online, and making sure the information is correct in terms of the council's provision. And then where possible and feasible, given the backdrop of resources and challenges, is looking for ways to provide additional public toilets, particularly in areas of low provision. So as I said, various members come together. We meet quarterly. We also have a resident who attends that working group as well, and that person was a member of the Southwark group for loos, who I think came and presented to you back in 2024. And so we've welcomed that resident to join our group to check and challenge the work we're doing, to sort of bring a resident's perspective, and we found that very, very useful. We've also sort of set ourselves an annual framework of jobs to get done in terms of making sure that this is an ongoing piece of work, and that annually we do things like check the data, update where necessary, make sure that we roll out the comms on a regular basis and that we're telling people what's happening. And we've sort of provided a high level sort of detail of that annual framework that we're sort of setting ourselves as a group to adhere to each year. One thing that perhaps in the toilet action plan isn't really sort of set there, but I've sort of set it out in the report, is some of the investment that's happening at the moment in terms of public toilet provision. So we know at the moment we're in the middle of a project to redevelop the public toilets at Peckham Rye Park. They were in very poor condition. They were subject to antisocial behaviour and vandalism. So we're just currently waiting for bids coming back from contractors and are expecting to be on site in mid-February with the hope to conclude and be open again in the spring. An additional project around, again, it's around existing public toilets, is officers are looking into the possibility of investing in East Street Market public toilets. We know they're very busy public toilets, and that they're at the moment looking at options for funding. They've identified the works that need to be done, but they're currently looking at funding sources. Another exciting development in terms of existing public toilets is currently Dulwich Library is being refurbished, and it's due for completion in July 2026. Part of that refurbishment is that the current public toilets are being redeveloped as part of that project, so they will be improved. But there's also going to be an additional public toilet on the first floor to be more accessible. A new provision that we don't currently have is that Brandon Library is undergoing a refurbishment project, and that is a new public toilet will be included as part of that refurbishment. That's an example of where we are looking for projects where there are council buildings that are being refurbished and there is an opportunity to provide a public toilet as part of that refurbishment. And particularly in areas where there's low provision, and so Brandon Library would be an example of that. So that project will include a new accessible toilet, and we're hoping to begin the works in February and be completed in the summer. Also, off the back of that, we will then ensure that that public toilet is listed on the toilet map online. It will also be listed on the council's website for public toilets. So it's each time a change in provision, we will then make sure that communications are updated so that people know that the public toilet is there. There's also a new provision at Canada Water Leisure Centre which opened in the autumn. There is actually now a new toilet which is on the public facing side, so people don't have to go into the leisure centre to access a public toilet. It's before you go through the barriers, and that's an example of where, as a council development project, we have also sort of met the public toilet agenda of better provision by providing something that can just be easily accessible without having to go into the actual centre to use them. There's also, as part of that development, a new train changing places toilet within the centre, and anybody who would need to use that can access that as well. Off the back of the recommendations, we recognise there are some challenges to some of the recommendations. One of them was around the community toilet scheme. The position remains the same, that there isn't any resource to deliver a community toilet scheme. However, the local economy team have taken measures to sort of work on this and try and work with local businesses to improve access and encourage them to put their facilities where it's feasible on the toilet map online, and then we're going to continue to monitor that to see if their uptake improves and that we have more availability across the borough, particularly in areas where there's low provision. Also, I think the The report made a recommendation for a public toilet strategy. Unfortunately, again, the position is still the same in terms of resource to do this, but that is where instead we've provided the toilet action plan to work on all of the other recommendations and then report back here on the progress with that. So despite those resource challenges, we do feel that there has been progress. We definitely have a much more coordinated and collaborative approach across the council to work across the teams in better provision and raising awareness of that provision. We're very much mindful that whilst we can't necessarily go out and provide lots of extra public toilets, it is also about the quality of the ones we have already, and we're working hard to try and improve that, and we know that there is improvements to be made. We do think it's positive that there's been completion of capital projects to improve provision, and that there are some in the pipeline as well, and we think this is positive. We think the data around public toilet provision in Southwark is improved, and we know that the toilet map is up to date, and we'll continue to monitor that. We're also doing a piece of work around trying to sort of look at how we can put the provision on Google Maps, because we know that a lot of people, that is probably one of the first places they will go to find a facility. Also, a big piece of work is around the communications. We have a new campaign that's going to be launched in the spring, again, that is hoping to direct people where they can find information about public toilets, and also working with our communities team around also getting the information out to people who may not necessarily access the digital forms. So being more equitable in that sense, and then a refreshed focus on working with local businesses and our local economy team, and things like the sort of the local economy e-newsletter, making sure there's a call to action for local businesses, if feasible, for them to open up their customer toilets to the public. Included within the paper is the actual action plan. It's in a lot more detail. I won't necessarily go into that now. And also we've included a list of the council's 37 public toilets. Hope that's okay.
Thank you very much. When we first went into this public toilet situation, it was because our residents were complaining, the elderly ones, that they were afraid to go out because they didn't have toilets to go to, and they didn't want accidents on the road and all that kind of thing. And just about then, they removed the Camberwell, the toilet, the one you put the money in and go to, from Camberwell. And a lot of toilets then, they were shutting them down, saying because of antisocial behavior. So we asked if they could not look at a way to prevent antisocial behavior so that these toilets will stay open and build more. And you talk about East Street. I've been to East Street toilet back in the days when I used to go to East Street Market. They used to have a lady there during the daytime, and she's there 24/7 till the market or the toilet closes. So, I mean, why can't we have that in most places? And people used to, like, if you're happy with the cleanliness, you drop something, or however they want to do it. Or if they have more public toilets where people have to pay and use them. So I don't know. And I'm going to pick on the toilet in the Camberwell Library. I'm being told that it's not cleaned as many times as possible. So when you go to the Camberwell Library, the toilet is not always clean. It's either water on the floor, no tissue. It's always in a mess. So I don't know if they don't have the money to employ someone to clean it more than once a day, or how do they run it?
So you make some interesting points, particularly around antisocial behaviour, and this is a challenge that we often have to deal with. So part of the working group is the community safety team are working with us. We find it particularly challenging in public toilets that aren't staffed or in a public building such as a leisure centre or a library. So, for example, my own team in parks, we do have to deal with antisocial behaviour every now and then. We're working with our park liaison officer team to ensure that the public toilets are on their patrols. We have we've put posters in the parks about how to report antisocial behaviour, and we continue to monitor that. Also, for example, Peckham Rye Park is an example in terms of the refurbishment of that space. We are making it really robust, or as robust as possible, to try and make these spaces less desirable to people who want to carry out antisocial behaviour. So yes, so it is a problem, but I think that where possible, if we have staffed facilities in the sense of a building that, say, for example, like a library or a leisure centre, the antisocial behaviour doesn't tend to be as severe because obviously there are people in the building. So that's why I think we're working with our sustainable growth team to look at the opportunities for increased provision where it's in a public building, because we find that helps to tackle those issues.
And if I can just add on Camberwell Library, so there is a contract in place across all the libraries, and there have been some contractual issues which have been disappointing, which we're working on with colleagues in our facilities management team to address. So it has been brought to my attention and to the Head of Culture's attention, and it's not where we'd like it to be, but we're working hard to ensure that our contractor improves that position. So we're reporting everything to them, and clearly working with our colleagues to ensure that contract is managed in the way it needs to be.
And sorry, just to touch upon your point around payment for toilets, we obviously are trying to avoid that because we feel that we want to be welcoming to everybody, and that might be a barrier for some people, but also challenging times for most local authorities, which is why we're trying to work with local businesses, but also looking at provision going forward in terms of seeking out those opportunities where we do have building redevelopments on how we can improve public toilet provision within those, rather than standalone provision.
Thank you very much for your presentation. I'm quite passionate about public toilets. Not everyone finds it very sexy, but I think it's really important. So I'm a councillor in Rye Lane ward, and in the Rye Lane area we've got a bit of a dearth. So again, like Councillor Batchel, we had one of those unit things. It was on Atwell Road, and it was closed down even before I became a councillor due to drug taking issues and stuff like that. And then in the station redevelopment, there are going to be toilets, but they're going to be behind the barriers. So I don't know which resident you've got on your group, but we do have a local resident who's very passionate about it, Eileen Conn. And in the planning agreement for the Station Square, apparently there is provision for toilets, but my understanding is that the Sustainable Growth team do not want to do it. And the reason being is that they think there isn't a way to manage antisocial behaviour. But I just think, you know, this is an issue in every town, in every country in the world, isn't it? And I can't believe that there isn't a solution. Do you know what I mean? Like I see some weird solutions come up sometimes. Something came up the other day where there was a toilet which was see-through, and then you went in and then the glass went, you know, I'm like, I don't like, A, you wouldn't trust it, would you? And B, who wants to see it invisible at the sun? But I don't know whether that was designed like that to prevent drug taking and stuff. But so I'm not proposing that one, but I'm just thinking there must be a solution. And I don't know whether the whole Station Square redevelopment thing in front of Peckham Rye Station, do you happen to know whether it's an absolute, like, is it 100% no, we're never going to get toilets there, or is it still a potential? Do you happen to know?
I think when I looked at this and liaised with the Sustainable Growth team in terms of the update for the action plan, they sort of earmarked it as still a work in progress. So I think they're still exploring something because they see the need, but they did also mention the toilets at the station as well. So I can perhaps go back and I can perhaps go back to them and find out a bit more for you.
We were often given the answer that the new Aylsham development would be providing the town centre toilets, and but we don't know whether that is or isn't going ahead as of yet. And also, I just think, yeah, it's ideal not to pay for toilets, but if it's a choice of paying for a toilet and not having a toilet at all, I think people would still prefer to pay. Do you know what I mean? I just know that it just stops some people going out at all. Do you know what I mean?
I think sort of linked to Tara's point, yes, we're actually pretty passionate about toilets as well, just to share that. Seriously recognising the impact it has on people's lives. So yeah, really, really important. And I think one of the ways that we can unlock some additional provision whilst being mindful of the resource issue for the council is the work that Tara and others are doing with the economic development team, Danny Edwards and co, because lots of vision that they could make it accessible. It's worked in other places, so that might be a way of doing it in a way that becomes less of a resource drag. I know there's some good work going on there, but clearly there's more to be done. And I think in terms of paying, in order to, I use the word wash your face, I suppose wash its face, it probably, in order you'd have to probably charge quite a fee to make it wash its face and you need toilet provision with the sort of staff people in it.
And I think it would be important to stress that, so the working plan, the toilet action plan, in terms of the group, as far as they see it, is a working document. So they're working through various actions that we've set ourselves that we feel achieve the objectives and the recommendations set out in the report. But once we move on from one action, we're looking at, well, what more can we do? And that this is an ongoing programme of work around public toilets, that we're working across all teams together to identify opportunities where they're feasible and where they're sustainable as well. So I think it's important to stress this is a working document. It's not set in stone and probably will hopefully look different in the future because we'll have got some of those things completed.
Just one last question. So obviously, traditionally you might have a pub and it'll have a sign, toilets are for customers' own use and all the rest of it. So in terms of working with, you mentioned the Danny Edwards team and the local businesses and all the rest of it, what would be the incentive for a local business to open up their toilets for white? How do you go about persuading a business that this would be a great thing to do?
There are different measures that we're looking at the moment, and Tara might be able to give you more on that, but some of it's also about signposting people to toilets that are readily available. So, for example, a Sainsbury's or a Tesco's or whatever will have toilets, but are they actually on the toilet map? Do people know that they're there? So it's opening up communication about existing provision, but then there are various incentives being explored, but again, they come at a potential cost. But I don't know if you wanted to say any more about that, Tara.
It's also looking at, we're sort of talking, well, we've made sort of connections with the NHS to see if there's any opportunities with any of their buildings. That remains to be seen, and we're going to have those discussions. But in terms of local businesses, it's also about community spirit and being part of a community. And we know that there are some businesses that are in a better position to do that than others, and we accept that. But it's also looking at where the gaps are in a town centre. So we know, for example, Rye Lane at the top, we've got the leisure centre, we've got the library, but at the other end, it's a little bit more challenging. And for some people, that's a good sort of 10 to 15 minute walk to get to the other end of Rye Lane. So, it's looking at the opportunities where they're going to be most useful, and that's where our town centre managers are really invaluable. Is that the right word? Valuable?
Invaluable.
Yeah. Said everything, yeah.
Do you think there might be a potential, like after all the station work is done at Peckham Rise Station, even though the toilets are behind the barriers, that we could have some kind of arrangement whereby the toilets can be used even if you're not travelling on the train, or do you think that's impossible?
I think we probably need to go away and register your questions and ongoing sort of requests for more information. I don't think either of us are probably equipped to say yes or no. It sounds sensible, but there are probably some very good things, reasons why it's not as easy as it sounds like it should be. But if we talk to the Sustainable Growth team and come back to Julie with their response, if that would be okay.
I just think we should have them in the station square. There's loads of the arches there. I just don't see that we can't have a solution to dealing with ASB. Do you know what I mean? We're not the only council in the country that, and the Age UK have done reports on this, and haven't they? Do you know what I mean? Yeah, I'd really, really like us to get some public toilets in the station square.
We will take that messaging back, clearly.
Talking about organisation, I know that in Camberwell, McDonald's, if you haven't got a receipt, you can use the toilet because the code is on the receipt. McDonald Camberwell. So even if you want to use their toilet, you have to buy something, and then you get the code, and then you go to the toilet and you put the code on the door. And if you go to Morrison in Camberwell, there are no toilets there. So it's like a shame that you have all these big shops and none of them even have a toilet for their customers to use. Shouldn't we be enforcing things like that on them to have toilets for their customers? So at least someone can take a basket and go and use the toilet and come out the next door.
I guess it depends on what levers we've got to pull within the planning system, and it's probably down to square footage in terms of what provision needs to be provided depending on the size of the shop. But again, if you say it's a big Morrison's, I don't know that Morrison's, but that would be the usual sort of levers we pull. It would be dependent on the size of the development and also the time when it went up, because legislation changes, planning rules change over time. So I don't know that specific answer, but I think it will depend on the size of the establishment.
Thank you.
Nice to meet you.
Yes, item 8.
Yeah.
So, yeah, the main issue, I think, is to confirm whether you don't want to have a final meeting on safeguarding. It's down there because if you wanted to interview do the annual interview of the safeguarding board chair, Anna Berry, which is always been, I think, quite useful and is good practice, then it would necessitate having an extra meeting. And in addition, you could include a report on FGM, because there wasn't time or either for officers to prepare that earlier, and there isn't really agenda space anyway. So it was an opportunity to look at safeguarding the chair and to have an item on FGM, and also to wrap up the final report there, which would probably all sit well. And I believe that you can do the 17th of March.
Oh, so I just looked on the phone. There's something down for the 2nd of March. Is that not?
That is going ahead, but it would be another meeting.
Oh, so 2 more.
We need an extra meeting.
Yeah.
Do we?
Mm-hmm.
Well, if you did want to do the have FDM and also do the annual interview, you can't do everything in the time available. The safeguarding chair, Anna Berry. Do you remember you? Yeah.
What about the annual interview of the cabinet member?
That's at the next meeting.
That's on the 2nd of March.
Yeah.
Oh, okay, great. A couple of weeks ago, I just said to you that I was sure I was going to be back here after May. I think that's not necessarily so safe now.
Oh.
In view of some recent news.
Oh because you're going for cabinet.
No, because we had a defection and Royal Lady's been targeted by the Green Party. So it's not clear that I will be back after
The mic.
Do you still want to go?
Oh, do we still want to record?
Because it's still live stream.
Yeah, no, it's fine. It is still live streaming.
Yeah.
Although sometimes we do.
All I wanted to say is that I'm keen for us to wrap up stuff that we've been working on for a while.
Yeah.
By the end of this, what do you call it?
Municipal year.
Municipal year.
Yeah.
Thank you very much. And things on my mind are things like, do you remember we got the statement from the lady who had a mother with dementia around locking her door? Joan Thomas, it was.
Yeah.
Yeah. And then we had the interview with Grant Malin, didn't we?
Yes. So that would all be wrapped up in the safeguarding report, and that's down for the last meeting.
For the 17th.
Yeah.
Okay.
Yeah, if you can make the 17th and and you formally decide that, then yeah, that would be the
17th of March. Yep, I can do that. So what's on the programme for those two meetings, and is it in here?
It is, yeah.
What page is it on?
If you turn to the supplemental agenda, and it's page 37 and 38 has got the work plan. Do you want me to just read it out? Yeah, so the next meeting, subject to confirmation, we've got an item on TfL and London councils, which is looking at the freedom pass and driver behaviour. And then we've got down to invite Age UK or Southwark Pensions Action Group or some representative from older people's groups, locally or nationally. Then we've got the confirmation that we'll have the interview with the Cabinet Member for Health and Wellbeing. And then we've got a scheduled report back on GP appointments. Then we've got the cancer review, the final report, and we've got looking at the safeguarding scrutiny review headline report. And then the final meeting is FDM, looking at work to prevent girls coming to harm, work with adult women on recognising and healing trauma, an interview with the Safeguarding Board Independent Chair. This is subject to her availability, and the Safeguarding Scrutiny Review report.
That looks like quite a lot for Monday, the 2nd of March. Do you think it's doable, yeah?
For the 2nd of March, well, we've definitely got the interview with the Cabinet Member for Health and Wellbeing, and we've definitely got the GP appointments, and the cancer review report is pending completion. There's just some extra information on blood cancer. The Mayor of London and TfL, that isn't confirmed. It is quite a lot, I agree. And the work on the blue badge scheme, it is a lot. I mean, you could just do the interview with the Cabinet Member and the GP appointments and the cancer review and the headline report. I know that other members, I think Councillor Charlie Taylor was quite keen on looking at driver behaviour. Possibly the London-wide work on the blue badge scheme. I think actually I would recommend that that's deferred, because I think asking that kind of question, you're going to get a better result if you give people 6 months notice rather than a month, because you really want to pose the question. So you could just stick to looking at the freedom bus pass and driver behaviour, or just drop that item.
Who was going to come along from where?
So TfL, but there's an invitation still got to be sent. So I'd have to find that, whoever that might be.
Yeah, I think it's too much for one meeting, and I think blue badge is fair enough to drop. Yeah.
Yeah.
And then so the 17th, we've basically got 3 issues. Yeah, FGM, safeguarding board, and safeguarding report. Yeah.
Yeah, I mean, I think that last meeting
Is better. Yeah.
is quite
More doable,
focused.
yeah.
Yeah. So you could just have the second meeting. What I could do is I could put some tentative feelers out to see if we can get somebody from the TfL on the bus pass, the freedom pass, and driver behaviour, and see what happens. My experiences with TfL is, again, they do prefer quite a lot of notice, so there is no guarantee. But you've definitely got the cabinet member coming, and you've definitely got GP appointments. Yeah, so you probably still have a pretty good meeting.
So if we send out the message to TfL and they can't make it for the 2nd of March, then we'll probably put them to the 17th of March.
I think possibly you're going to have too much there.
Oh,
Yeah, I think that's quite a substantial item. It might just be that you'd have to make it as a recommendation for next administrative year, but see what happens.
Okay.
Because it is going to be a new cycle, isn't it? Yeah. Do you want to draw the meeting to a close? Yeah. Okay. Yeah, we're finished now.
Thank you.
Thank you.